we have our Dr. Resmi Bhaskar coming up to give us an insight about the management of squint, which most of us are doubtful whether to refer to a strabismologist or can we wait until 1 year. So let's see what Dr. Resmi has to speak about it.
Thank you, Anita, for giving me this opportunity. Let's start with a lighter note. Should all children with infantile squint be referred for surgical correction? We will navigate through few cases and see whether it is a yes or no for surgery. The photos and videos shown in this are taken with the permission of child's parent. This is a case, one is a 2-month-old child, mother is a doctor, mother feels occasional squinting. It's a full-term normal delivery, external eye was normal, social smile was present. So what is it? It's a neonatal misalignment or physiological intermittent strabismus of the newborn. Up to 1 month, fixation will become central, steady and maintained, and by 3 months, binocular vision will develop and will have a coordinated eye movements. 88% of the infants will show brief periods of intermittent squinting. It will be intermittent, not constant. The deviation can be large but short-lived. It can be unilateral or alternating, and usually it will resolve by 2 months. So, if any child presenting it to you with a squinting more than 3 months of persisting more than 3 months, or if it is constant, that needs a follow-up. So what you will do for this child, you will ask them to come for a follow-up and see if it has resolved fully or you need further follow-up. The second is a 8-month-old child. The mother has felt that in all the photos the child has a inward deviation of the eyes. Hirschberg was orthophoric and the cover test showed no refixation movement. Refraction and fundus was normal. So it is a pseudo squint. As you can see in this video, we are doing a cover test. There is no refixation movement. When the child is small, you can do even with 2 fingers. The normal infants will have a wider and flatter nasal bridge, and this will give an appearance of a pseudo squint. Before you are labeling it as a pseudo, you call them again for after 2 months to reassess, because it can sometimes be an intermittent squinting with a good fixation that has not shown up in your first visit. So you always call them one more time and reassess before labeling them as a pseudo squint. This is a 4-month-old child. You can see a large squinting is there that has been noticed from birth, full-term delivery, and Krimsky shows almost 60% of esotropia, cross-fixation, normal refraction and fundus. And it is a case of essential infantile esotropia. This particular child with large angle squint, cross-fixation and normal refraction, you have to plan for a surgery early. The surgery plan from 6 months of age, surgical intervention can be done as shown by many studies. The advantages are better stereopsis and early binocularity, reduce incidence and severity of postoperative DVD and IO overaction, minimize the delay in sensory motor and motor development, and improve psychological and parental bonding. So, infantile esotropia, you have to plan for an early surgery. This 5-month-old child with also an inward squinting. You can see the squint in the left eye, intermittent it was, fixing and following well. External eye was normal, fundus is normal, but here the refraction was +5. Accommodative esotropia can occur early also. It's an early onset of accommodative esotropia. Studies have shown that 15% of the infantile esotropia and 8% of the accommodative patients have an infantile accommodative esotropia. So, cycloplegic refraction is a must for all children who comes to you with squinting. You can ask them for a atropine refraction or whichever cycloplegic, you have to give a cycloplegic refraction, and if the hypermetropy is more than +2.5, you have to give glasses. They see this child, they have come back with the glasses and she is orthophoric. The next is a 3-month-old child, squinting noted since birth. This is a divergent squint. Head control has been attained, but it's a constant exotropia. Almost 40 to 50% is there, freely alternating. Refraction and fundus is normal. This is a case of congenital exotropia. This is also a large angle, but they have poor binocular potential, and in case of congenital exotropia, you rule out neurological problems, and early surgery is advised in this child also. This child, 11-month-old, was referred to us from Sri Chitra with a history of developmental delay, facial dysmorphism and microcephaly. It was preterm with birth weight of 1.6 kg. You can see a alternating esotropia, right convergent to alternating. Refraction fundus was normal. But in spite of all this, the child is easily allowing you to do a cover test, and you would get a good measurement with the Krimsky also. The child was willing for allowing all that. So this child also should be referred for surgery, because surgical surgery for children with developmental delay, they well tolerate and effective. Only thing is the angles can be variable. You are sure when you get a correct measurements and you feel that it is constant, you can plan for a surgical correction. depending upon the assessment, and angles are if normal, angles are stable, and if you after you get a neurology fitness, you can plan for a surgery, because they have a chance of fusional potential. It improves the quality of vision and life of the child. So this case is I am showing two cases. One is a 1-year-old child, preterm, 24 weeks, status was ROP laser. He has an alternate convergent squint. The other baby is a 9-month-old, that also preterm with no retinopathy prematurity with intermittent divergent squint. When you check the refraction, both are high myopia, and squint and refractive error is common in preterm children. And so in preterm children, in addition to going for an ROP screening, you ask them to come back for refraction and squint evaluation at 6 months, and the risk increases with the severity of ROP also. So in this child, we have given the glasses and advised patching, and depending upon how they are doing with the glasses, we can plan surgery accordingly. This is a 7-month-old child with the left eye squinting constant, and she was resisting occlusion of the right eye, showing that the left eye has a poor vision. Fundus examination showed a coloboma. These are some of the common fundus findings we have come across in children who presented with squint, optic atrophy, ROP, retinoblastoma even in a 6-month-old child, vitreous hemorrhage, choroiditis, and familial exudative vitreoretinopathy. All kids coming to you with squinting, you have to do a fundus evaluation. That is mandatory. If at all the child is not allowing or anything like that, you plan for a examination under anesthesia, but you cannot miss a fundus finding of grave conditions like this. 6-month-old child, mother noted squinting and normal milestone. On examination, you can see there was a face turn to left. When the head posture was corrected, he had an esotropia with -2 limitation of abduction. Refraction and fundus normal, it is a case of Duane syndrome. In congenital cranial disinnervation disorders also, the indications for surgery are abnormal head posture, squint in primary position, upshoot and downshoot. So after you get a good measurements, you can plan for a surgery, even indicate. This is slightly older children, 1.5-year-old, but still because of the importance of this case, I am showing this. Complaining of squinting right eye, and he gives a history of subconjunctival hemorrhage at the time of birth, forceps delivery. See, she is resisting occlusion of the left eye, but when the right eye is closed, she is allowing it. That is with the right divergent squint, showing that the right eye is amblyopic. She had a cataract in the right eye. As madam has told, cataract also external eye examination you can do with the help of a Bruckner test, direct ophthalmoscope, handheld slit lamp, and for courageous person like Thomas, you can use a flying baby technique. I am still scared to do that. Or if you have any doubt, you plan for an examination under anesthesia also. So prevalence of squint in children with congenital cataract is around 20 to 80% before and after surgery. It can be ESO and exotropia. Other visual deprivation factors include corneal opacity, dense PPM. This have to plan for a cataract surgery at the earliest, and amblyopia treatment also. Some studies show that you can combine cataract and squint surgery also, but that is controversial. The last case, it's a paralytic squint in children. If a congenital palsy, fourth nerve is the commonest, but in case of acquired causes in infants, it is a red flag. It can be a sign of hydrocephalus, brain tumors, or demyelination. So you have to send for an urgent neuro evaluation and imaging. A study showing the profile of infantile strabismus at a tertiary eye care in India, it shows that 123 children out of 4773 had infantile squint, boys and girls, and equal preference, and esotropia was the commonest. And esotropia was common in prematurity, hypermetropia, and anisometropia, and exotropia in seizure session, delayed cry at birth, infantile seizures. And out of the 123, 29 underwent squint surgery. Take home message is constant squint or squint persisting more than 3 months is significant. Cycloplegic refraction and dilated fundus is mandatory. Constant large angle squint need early surgery. Timely referral and early surgery can preserve binocularity. Thank you.